Lovely. So, welcome everybody, and a particular welcome to Dr. Krissie Ivings, who's joining me here for this interview. I've been really looking forward to this for as soon as even before we scheduled it, I was looking forward to it because we've been communicating back and forth on a few different things. And also, Dr. Krissie has been making fabulous contributions into our membership hub when different therapists or trainees have posted questions, and she stepped in with such a experienced, calm, respectful, but full of wisdom comments that have been so helpful. And I've just loved having your contributions there, Krissie. It's been fantastic. So let's get started, and I'll give everyone an idea, a little bit our agenda here. I want Krissie to introduce herself, tell us a little bit about her background and work in the NHS and the different things she did there, which is quite interesting actually, and then get into a little bit of discussion around deciding to take a course in hypnotherapy when you're already a very experienced clinical psychologist who's done some really interesting research and already developed lots of really interesting things. So why and what was the impact of that? And then obviously, as this, we're going to talk about her current work as well, both with Aspire Therapy Services and also Aspire Equestrian. And in this way, I think we'll navigate through different topics and also look a little bit at some of the work Dr. Chris is doing for us right now in risk assessment, which we'll talk about, and then also have a little chat about smoking and vaping, perhaps. I think something that's dear to our heart here, and Chris has done some research in that area and has some quite strong views on that. So we'll see if we can drop that into the end. I think that's worthy of a whole little webinar in its own right, personally, because I think it's a very hot topic and it really needs some attention and some strong views, I think, on that we could bring to the table, perhaps. But that'll drop in the end, and we'll be very happy to have your questions here as well. So do pop them in. So that's the plan. We'll run till 2:30, if that's okay. And Krissie, yeah, tell us a little bit about where you're connecting from, where you originate from, how you got into clinical psychology, and when was that?
Okay, so I've had a very varied kind of career and life. I was born in Hong Kong, raised in Hong Kong, originally applied to do English at university, then decided to do medicine at university. So did 3 years at medical school in Sheffield. Realised I was much more interested in how people think and feel about illness than I was about actual disease pathology, and decided to make the shift over to clinical psychology. Which wasn't particularly wise because I had no idea at that point that it was so hard to get onto the clinical psychology doctorate. I thought, well, I'm a medical student, they'd be happy to have me, of course. And the college, the Sheffield Medical School, wasn't particularly happy that I was leaving after 3 years either. My parents were absolutely outraged at the idea I was going to throw away a proper job to do that kind of airy-fairy psychology nonsense.
But when was that? Was that in the
I was at Sheffield 92 to 99. Oh gosh, I have to work backwards. Graduated in 98 from clinical psychology, which means I started the course in 1995, which means I did my assistant psychology year in 94, which means I left Sheffield in 94. So I went to Sheffield in 91.
Okay.
I have to go backwards. I can't.
10 years after me at Sheffield, because I was at Sheffield
Oh, were you? Okay.
in
So
doing
yeah,
some.
medicine, 3 years, which was very interesting. But I spent my life looking down microscopes and not being able to have conversations with patients, because you do something and then go off and read results and look at disease pathology. And the good doctors that I knew, who I admired, were fascinated by the science of it. So yes, they had great bedside manner and that was important, but that wasn't what intrigued them about the job. It was they were medics. They loved the process of working out how this incredible cancer divides and spreads and is completely indestructible. And I was thinking, I'm not interested in that. I want to know how it feels to be the patient with that. So I left. Luckily, it did work out. I got onto a clinical psychology doctorate within a year of leaving Sheffield, which was, in retrospect, extremely fortunate because there's a massive bottleneck, as I'm sure people might realise, to get onto those courses. I did my clinical psychology training in Manchester, and did my PhD, my doctorate in smoking cessation. So that's kind of where my career started. It's been years and years and years since I've done anything in the field of smoking cessation. So although I'm interested in talking, I'm happy to talk to you about it. I may be embarrassingly out of date because I haven't kept it up. But my PhD was interesting because it compared, at the time, Alan Carr, the easy way to stop smoking guy, was very big. And his book, which I read and found very helpful to help me stop smoking, it wasn't his ideas, which is the kind of what I describe as the cognitive shift, the reframing of smoking as something desirable that you have to then find a way to overcome and replace the benefits with other things. And that was still the prevailing model in the NHS. It was like, oh, well, you need to find other ways to relax and you need to find other ways to cope. And actually it's like, well, where is the cognitive shift in mainstream NHS practices? So I contacted a consultant psychologist who did NHS smoking cessation services and said, how do you fancy comparing yourself to Alan Carr directly in a randomized controlled trial? And both Alan Carr and this consultant in the NHS they both thought that they were obviously going to absolutely outshine the other by a country mile. Because he's Alan Carr, and felt that he was, but nobody else could possibly get close to his quit rates. And the consultant NHS guy who thought, well, I'm doing a 6-session protocol with all the evidence-based practice. And Alan was doing a 2-session protocol, which is the standard protocol. Basically teach everything you need to know in session 1 and then follow up a week later or a month later. So I set that up. It was really interesting. Alan sent his therapists up to me, but they were stripped of their titles and their Alan Carr affiliation. They were doing the treatment in an NHS setting on plastic chairs in cold rooms with crap tea. And not surprisingly, his quit rates plummeted from that because people weren't spending 350 quid to go and be taught by the guru. They were sent there by their GP. And they were sort of there reluctantly going, I'm here because I want NRT and I won't get it for free unless I come and talk to you first. And that was in both groups, obviously. And anyway, the results were completely comparable. There was no differences in either group, which I thought was really interesting and both the NHS guy and Alan were outraged. They both got good quit rates. I mean, Alan Carr told me in a kind of personal communication he was expecting, he quoted 90% plus quit rates. In fact, he said he reckoned it was about 50. Because he knew that paying made a difference, but he underestimated the impact of all of that. So they all got about 20.
About 20.
About 20 at 1 year follow-up. So
that's quite challenging, the 1 year follow-up, isn't it?
Yeah.
Did you lose people? That was a biochemical follow-up, or
that was self-report, but we did use intention to treat. So the 20% who had quit were people we got hold of. If we couldn't get hold of them, we assumed they hadn't quit.
Right.
So we didn't kind of, it was pretty robust that unless we've heard from you and you're saying, yes, hooray, I'm free, you weren't counted as a success. So anyway, that was my PhD. I then went and worked in adult mental health, in psychosis, then addiction services for a bit. And finally, after about 2 years after qualifying, I found myself in CAMHS in Stockport. And I've had the rest of my career in CAMHS in and around Greater Manchester.
Just to unpack the acronym for people who aren't acronym.
Oh, CAMHS, sorry, Child and Adolescent Mental Health Services.
Okay, fantastic. And so you've done quite some considerable work there, I think, when you were in the NHS there, yeah?
Yeah, so I carried on working in smoking cessation 1 day a week. And then the other 4 days I was working child and adolescent mental health. I was in a mega trust where there were 6 boroughs. So Stockport was 1 of 6. Across Greater Manchester, we were by far the worst performing borough. We had waiting lists of 18 months. We had really poor services. We had a horrible turnover of staff. We had nobody. And eventually my supervisor and the consultant lead at that trust left after I'd been in the job about 4 years. And they tried and failed to recruit and offered me the job, which is quite soon to become a consultant, 4 years. But I didn't want to leave Stockport. Nobody else was applying for the job. So I thought, well, give it a go. It was interesting psychologically because I had done one of my trainee placements at Stockport, and half the staff team there was still there, remembered me, people who'd been there years and years and years. So for them, I was still a student. And all of a sudden, I'm consultant lead, clinical psychologist, head of service. which meant that imposter syndrome was absolutely huge, really, really difficult. But there was so much to do in terms of service development and service, just culture change. I hadn't been in a position to do anything about any of the problems when I was the junior psychologist in the service. But I just decided that if I'm going to have this job, I might as well bite the bullet and swim upstream and just make stuff happen. So I got involved very early on in my career in change management programs. And the first one was something called CAPA, which was a capacity demand initiative, which got the waiting list down to 0, which was really good. And then I introduced IAPT into children and adolescent services, which is increasing access to psychological therapies, mainly CBT, because CAMHS at that point didn't really have any CBT in it. By then, I'd got my BABCP accreditation in CBT. So I thought, well,
you've done a master's in CBT now, the site, because that's a master's level usually to get that. Is that?
Well, I had the doctorate already, and as part, because I was on the Manchester course, which is a very CBT heavy course, a lot of the master classes that I'd done with people who taught on the course, like Paul Salkowskis, David Wells, Adrian Wells, David Vine, they all taught. Jill Haddock was a tutor on the course. Adrian Wells was the head tutor on the CBT domain of the course. I had my supervisor at one point. So they accepted my credentials as a BABCP accredited therapist. So I didn't have to go and do another diploma, luckily, because I spent quite a lot of time at university already by then.
And let me just ask you there. I mean, this is just fascinating. Your views on IAPT, because obviously it's it's been a huge initiative. A lot of people got trained. We brought in now this idea of, low intensity and now psychological well-being practitioner, which I think really opens things out. And on the private side, we're kind of, tracking somewhat similar, I think, in a certain way. But also it's been in for a lot of criticism as well. And I'm just interested in and a real concern that a lot of counselors and good people who are doing good work, that all got kind of thrown out in the sort of CBT wave, so to speak. What's your view on that? And that might have evolved from the initial success to things getting a bit more stuck now. I don't know.
Well, I've been out of that world for a long time, but I was involved in it from the beginning. So all I could say is kind of my experience of it back then. I think that as an initiative then, it was really sorely needed. Because CBT was an evidence-based psychotherapy which was effective, particularly for anxiety and depression, which was what was most people going to their GP with. And I mean, the original impetus for IAPT was to get people back into work. And that caused a lot of controversy because there was this idea that it's punishing, it's a kind of work agenda. But actually, the original kind of conception of that was because being out of work is very bad for your mental health. Obviously, it's better for society if you're in work, but it's also better for you. Because being out of work, as soon as people begin to struggle emotionally and they start giving up things that they enjoy and they lose structure, they lose self-efficacy, they lose contact with other people, they lose a sense of purpose, and it's really harmful. So it wasn't, people had ideological objections to it in the first place because the purpose of it was to get people back into work, and the whole funding of it came from, well, people will be back in work, so the money we're saving is funding this. But
yeah, the
I didn't really
layout report. Yeah,
I thought it was a well-conceived idea, and the course itself was extremely robust. The IAPT training, among my many jobs I had alongside my NHS work. I'm a bit of a magpie. I just do stuff. I was asked if I would get involved in the Chester course, which is one of the IAPT courses, and I became a supervisor for adult IAPT trainees and then an external examiner examining the tapes. And the tapes were really thorough. You rated them against this cognitive therapy rating scale. They had to be good, and the quality of them, as you went through the course to start with, was really poor, which was quite frightening because these were people who were already mental health practitioners working in the NHS in settings and treating adults with mental health difficulties, and they had absolutely no idea how to structure an intervention in a way that was adherent to the evidence base. They were making really obvious mistakes that are easy to make, but just make the treatment completely ineffective. For example, I remember at one tape, somebody was treating blood injury phobia and was exposing the person to various images and at the point of highest anxiety, when the patient began to get kind of really agitated, they said, right, well, I think you've done really well, we'll leave it there. Which is, for those who have finished the course, you'll know why that's crazy. For those who haven't finished the course, you'll learn why that's crazy. But believe me, that is completely ineffective. to stop the intervention at the point that the anxiety is at its peak, as opposed to waiting for it to habituate. So yeah, I mean, these were people who were already working in the NHS as therapists. So I thought that the robustness of it, the scrutiny, the governance around it was really, really good. And the people that came out with the qualification, they were needed and they did good work. And it also meant that psychological therapies were accessible, because certainly at that time, I don't know what it's like now, and I noticed there was a GP from Manchester on the call, so perhaps you can tell us. But you were then able to go to your GP with anxiety or depression and be given access to a psychological therapy with an evidence base, which was a lot better than it was before when I first started working in this sector, where you got drugs, medication, and pretty much not much else, unless you were willing to wait for a very long time.
I think it's the limitation over the number of sessions that I think, and the sort of the strictness of the protocol. Sometimes I
Yeah.
think that's the challenge, perhaps a bit.
But if you look at the evidence base, it's a case of diminishing returns. You get the most bang for your buck in the first 3 sessions, and then a bit more for the next 3, and then not an awful lot left for the any 12 or 20 or 60 after that.
Interesting.
But yeah, individually, it's one of these things about, look at it population level, it's a good thing. Look at it individually, it doesn't always work. It's not always appropriate, because it did lack flexibility. You had your 6-session protocol. It was very manualized. So you had to choose the right people. But for those people for whom a manualized, very prescriptive, evidence-based therapy was appropriate, they did quite well with it, and certainly better than what they had before. Now, my involvement with it was as clinical lead for CYPI Act in the first wave of CYP Act, which was in Manchester. So we were the first service across those 6 boroughs that introduced CYPI Act. And if you think it was controversial in adults, the controversy in children's IAPT was really, really significant. But again, I stand by the comments I made with adults IAPT. There were practitioners who were working with kids who had definable mental health difficulties like anxiety disorders and low mood, who were not getting the evidence-based treatments because CBT just didn't really exist. Therapists or psychotherapists or art therapists or counsellors. They were not likely to be CBT therapists. In fact, I remember when I first started the job, CBT was viewed with suspicion as, tokenistic, short term, didn't get to the root of problems, was, so I was the CBT therapist. And I remember suggesting CBT once at a team meeting for someone with anxiety and being told, oh, I think it needs a bit more than that. For a child who had, school refusal. It's like, well, they're anxious. Let's try it, Yeah, so that was my CAMHS career. It was CAPA, then CYP IAPT, and then I gradually, slowly moved into crisis care, which is kind of where I've ended up.
Interesting. Before we go there, let's just ask about that, because I think it's, I was having some discussions online recently. There's some talk about regulating psychotherapy again, and I say, I think the danger is if you do regulation, there's going to be a whole bunch of people pushing for certain models that I don't think maybe have some problems within them. When we went to apply to join UKCP, which we've not gone ahead with, we had to apply to a particular college. That means a sort of division that's called outcome-oriented psychotherapies. The other 11 divisions, I guess, are not outcome-oriented, which made Don Meichenbaum fall off his chair when I told him. So this idea of, CBT, I remember Judith Beck said CBT is goal-focused and time-limited, and that being really important, I think, particularly when somebody's investing privately. And I just wanted your views on that in terms of goal-focused, time-limited versus, well, I don't know what the alternative is, but I guess it goes on for a while and it's not so goal-focused.
Yeah, I mean, goal focused, like, why would it not be goal focused? I guess it might be difficult to work out what your goals are originally. So, but that doesn't mean don't be goal focused. It means take time to properly conceptualize and figure out some sensible goals. And also evaluate goals. I mean, still, routine outcome monitoring is controversial within the NHS. Teams don't like it. Patients love it. CAMHS teams don't like it. They think that, I think one of the comments on the hub actually was, we don't like outcome monitoring, we don't like measures and things. But it's just information that allows you to track progress and actually allows you to celebrate progress and share progress and make sure that you're staying focused on what actually matters to the person. Because otherwise, you get therapeutic drift so easily where you meet somebody this is very, very common when I was supervising non-psychologists in CAMHS, was something I used to call issues arising therapy was my name for it, which was basically whatever it started off as meant to be being, it became a chat once a week about whatever had been going on that week. And it was, parents came and they liked it, and the kids came and they liked it, and it was fine. But what was the point of it? Where was it going? What was the purpose of having a friendly chat with a nice, sympathetic person once a week to talk about how your week's been? I mean, that'd be great if we could all have that forever. But it wasn't effective. So issues arising therapy is really not effective. And I guess that's the other 10 of your 11 things on the would just be kind of that unsystematic, unstructured, unfocused. So CBT, yes, it's goal focused and time limited. Unless you're doing a manualized protocol, CBT doesn't have to be short term. It can be, I mean, DBT is a branch of CBT and it goes on for at least a year, weekly. But it's still time limited because it ends at some point, and it's very, very structured, and it's very, very goal oriented. It's just super intense because the needs of that client group are super intense. And so that's it. That's what it takes. It takes a year, ideally, possibly a bit more, because they have to essentially, CBT helps people use the skills they already have access to, like some resilience skills or some coping skills or some communication skills. And DBT recognizes that people who need it don't have those skills, never learned them in the first place as a child. So they have to learn the skills from the ground up first and then apply them in practice in increasingly challenging situations. So that's why it takes so long. But it's still very, very focused.
Well, so let's talk about how your work evolved then into so what was the next phase of it then?
Well, as a LAC as the consultant lead at Stockport CAMHS, I was responsible for two different areas. Well, I was responsible for all of it, but the things that were bothering me about the offer that we had were kids in crisis, where I felt the service was quite poor, and looked after children where the service was absolutely abysmal. So the crisis kids first, they were problematic because they would turn up via A&E. Usually they would end up on a ward at the hospital, where the camp we were hospital based, our CAMHS team. So we would then, whoever was on call each day would see the kids that had come in overnight or the day before, and then we'd do a CAMHS assessment, risk assessment, and make a decision about what to do with them. And for a small subset of those kids, there was no real pathway that made sense for them because they weren't particularly anxious or depressed. They didn't have a treatable kind of issue that we could say they need X or Y protocol. They'd be fine the following day. Like, oh yeah, I had a bad day. I failed my homework task and my teacher shouted at me and then my mum had a go at me. So I went and tried to kill myself. So we're like, what do you do with that? I'm fine now though. And they would not, if you offered follow-up, they wouldn't attend. So you'd have 3 or 4 sessions where they might miss in a row, and then they'd turn up again via A&E, demanding to be seen instantly. Where's Krissie? Where is she? I need to see her right now. And I was like, she's not available right now. So there wasn't a treatment that we had that was effective for those very chaotic, but very, very emotionally labile children who just were fine and then completely in crisis and then fine again in the blink of an eye, and you couldn't really get hold of them. And if you did start working with them, if they did come, if they got dragged by parents or whatever, every session would be completely different because you'd be talking about anxiety and then the following week they'd be like, oh yeah, no, I'm not anxious anymore, but I did do the X, Y, Z. And you'd be like, okay, so now we're talking about mood. And now we're talking about, oh, I yelled at my teacher. I've been excluded for 3 days because I got too angry. So, okay, we're on anger management now. And it was like trying to fit jelly into, I don't know, that was a mixed metaphor, but it was just very difficult. And a lot of therapists and psychologists got fed up with these patients, and thought, that it's just, they don't want treatment, they're not committed, they change all the time.
And they can't get a diagnosis clear on them, which I think is, from what I've seen, then they spin around with multiple sessions, multiple psychologists. Nobody can land a diagnosis, and the psychologist trying to land a diagnosis to feel kind of confident, I think, to move ahead sometimes.
Well, yeah, I mean, I think people got frustrated with them because they make you feel completely incompetent.
Mm.
because they never got any better. They were often, either really clingy and demanding of you because you were kind of important to them, and then the next day they hated you because you were useless. And they told you quite hope. Anyway, this group, I did some research really about like what treatments are there for this group and came across Marshall Linehan, who founded DBT, which is dialectical behavior therapy, which is a really bad, inaccessible title for quite a straightforward therapy, really. Which is basically recognizing that this particular cluster of problems of being emotionally reactive, poor at communicating, poor at problem solving, comes from fundamentally a lack of skills. It's kind of attachment disordered children grown up. They don't have the skills they need to trust that their needs will be met. They don't have the skills they need to problem solve their own problems, to self-soothe, to cope, to manage. They're just chaotic and dysregulated and distressed. And very unskillful. So they interact with us very unskillfully, of course, because they are very unskillful. They don't have the skills to interact less unskillfully, because that's the problem. So DBT breaks down the presentation and says, well, this happens because of the lack of skills in these different areas. And also that the level of distress is extremely high because these are people who just don't trust that their needs will be met, who have been let down a lot, who feel very invalidated, partly because of whatever difficulties led them to be in distress in the first place, but then also system responses to their difficulties, because hospitals get fed up with them and CAMHS services get fed up with them and families and friends and parents and get fed up with them. So DBT was just looked to us to be a fantastic option. And if I'm ever going to do anything, I'll do it properly. So I contacted DBT Isles and said, we need to get an entire team trained in DBT. How much is that going to cost? Got told how much it was going to cost and applied for something called health innovation funding, where you could get, there was a pot of money that said, if you can demonstrate that this is needed, there is the money. And I think we got a grant of about £150,000 to train the team. And we had to evaluate the outcomes, and our inpatient bill, because the kids that get put on the, who spend 2 or 3 days on the CAMHS ward, on the paediatric ward before coming to CAMHS, get charged to the CAMHS budget because they're our kids. And our bill for that went from £800,000 in a single year down to £25,000 when we introduced DBT. So that these kids, instead of going to the ward, that was like, no, they don't need admission, they need to come into our service and have this very intensive wraparound, systematic, focus, skills-based approach. And it's brilliant. So that was the first.
And when you say intensive, multiple sessions a week, I mean, what's the kind of main part?
Yeah, it's a multimodal therapy. So it's there are 5 elements to it. One of which is one-to-one sessions, so 1 a week. And then the skills group, which you can't do the one-to-one sessions if you don't do the skills group. The kids don't ever want the skills group. They always want the one-to-one sessions. And so it's a bit, well, you can't have the thing you like if you don't come to the thing you need. So the skills groups actually have an evidence base outside of DBT formal program. One-to-one sessions do not have an evidence base outside of skills. So kids like this who have the one-to-one with a DBT therapist who don't do skills don't actually benefit. Oh, I'm seeing a question. This was about 20 years ago. I don't think the funding stream exists anymore, I'm afraid to say. Health innovation funding, it was called way back then. Not 20 years ago, but at least 10. So yeah, it's structuring the environment, mentoring the staff who are working in this team so that they don't get burnt out, so that they can maintain empathy and compassion for patients who are incredibly challenging. Skills groups, one-to-one therapies, and I can't remember what number 5 was. Oh yeah, crisis access to your therapist in a crisis. So yeah, very, very intensive. 2 planned sessions a week, and then access to a therapist in crisis anytime they wanted. But that very clear limits around what kind of thing you're allowed to call your therapist about and how you have to behave on that call.
Interesting. And diagnosis required or not? Because I mean, there's a whole issue around the diagnosis, personality versus. So taking them, but how do they get access to the service without a diagnosis? Kind of, meeting the cutoffs, etc.
So I mean, they had to be children who were in crisis. So they had to be presenting with self-harm or suicidality.
Okay.
At least 3 times in a period of about 6 months.
And then essentially this much more.
And then they tick the box that said you are distressed and chaotic and dysfunctional enough to qualify for this treatment.
And then there was
a very long, sorry, Karen.
Well, a transdiagnostic kind of.
It's
We're not going to get.
transdiagnostic,
We're
yes.
not.
It was functional. It was a sort of functional diagnosis. If you are behaving in these ways, then you would be suitable.
We don't need to label you.
We don't need to label you. In fact, if children had diagnoses, they'd probably be given an evidence-based treatment that was more appropriate for that diagnosis. So it's kind of for the kids that don't have a diagnosis that need it most.
Interesting. Well, I had a lot of discussions with Daniel about this issue about, transdiagnostic picking up this stuff that otherwise everyone can't slot them into these things and the people fall through or they're across multiple,
Yeah.
etc. So interesting. Wow, fascinating. So Siobhan, by the way, asked a question earlier. She said, in my experience, patients historically had a good response to CBT, however, more recently, less so. Therapy seemed briefer and feedback less positive, but that's because Krissie had left, you see, the practitioners. I wondered, did the length or quality of training reduce in some areas in order to get more practitioners out there to meet the demand? It might have been the way it's been managed as well. I don't know. Well, any views on that? How?
Yeah, well, I mean, I think the problem is that there probably are a lot more trainees now than there were. I'm not no longer involved directly, but I do supervise a clinical psychologist who is the IAP lead for her trust. And so she has people who apply for the courses, and there's enormous pressure to kind of pass people, as in approve them for training when they probably shouldn't be approved for training. They're not ready or they're not really experienced enough. And the other massive problem is that the only way IAP works is if it within CAMHS anyway. Because I think adults are slightly different because they had separate IAP services, but IAP was embedded within CAMHS. It wasn't just for adults. So it wasn't just the kind of service offering this thing. So if you train an IAP therapist as a CBT therapist, you have to then carve out a role for them that means that they get appropriate cases for CBT. That doesn't always happen. So you get trained, you become accredited by the BABCP, or CBT trained, and then you go back and you just get a completely generic caseload, where 2/3 of it wouldn't be appropriate for a time-limited specific CBT intervention. So obviously the outcomes are not going to be great because you're not matching the client to the intervention.
They're just
so I
putting them
think
out there to
probably it's
soak up.
mismanagement of the
Yeah.
process is the issue.
Interesting.
Or the
All right.
quality of trainees falling, or the quality of training falling.
Yeah, there was some views also in terms of the thing having to prove itself and being getting a little too kind of manualized and outcome oriented and losing some maybe flexibility. I don't know. I don't know.
Possibly, yeah.
Possibly.
Well, I mean, I
But
wouldn't work in an IAP way personally. So it's kind of again going back to population level versus individual level. If you're an accredited if you're an IAPT practitioner, you've passed the course, you are at least safe. You are going to do more or less evidence-based therapies more or less competently. That doesn't mean that you'll be doing optimum therapy. Once you become really good, you can flex. So I don't think any of my therapies ever look very much like the manuals anymore, because they don't need to. But I think that you really need to work with full adherence to the protocol for quite a long time before you decide to go off piste. Because actually, you need to be really, really well grounded in the basics, and then begin to become more eclectic. There's a kind of phrase within the Manchester course where I trained that eclectic is kind of euphemism for not very good at anything. So you just kind of mix and match. And I think that's a bit harsh. I would now say I'm eclectic, but whatever I've learned how to do, I've wanted to learn how to do it properly. Which I guess brings us on to why I chose your course, incidentally.
Yeah, well, let's go to that one.
To do it properly. So I got accredited. I got accredited as a DBT therapist. I went and got the intensive training by the DBT Isles, the leading trainer in the country for DBT, because I don't want to do things in a half-hearted, or I don't want to be not particularly good at the basics. I think there's a lot of people believe that they can do things better than they can. And unless they're actually scrutinized in the way that a course makes you be scrutinized, you're submitting tapes, submitting assignments, you don't realize that you're just not that good. And then you shouldn't be inventing new therapies or blending therapies if you're not that good at any of them that you're blending. If you can't do the core ones well, you've got no business to be blending them, in my view.
Interesting. Very interesting. We could dive into that. Let's talk about the other side of your work there with in terms of children in care. Yeah.
Yes.
Yeah.
Well, as I said earlier, the part of CAMHS that really kept me up at night was looked after children. They just didn't get a service. There was a tiny allocation of funding attached to looked after children, and it was nowhere near enough to meet the needs of those children. So, part of my role as consultant lead was service development. So I kept trying to find ways within the NHS to create a better offer. But there was always funding problems because the local authority pay for children's care, and not health. And so health never wanted to pay for something that they felt that the local authority should pay for. The local authority didn't want to pay for health stuff because that was health, and CAMHS should be supporting these kids. So it just didn't work. And in the end, so back in 2013, so 11 years ago now, I set up Aspire Therapy Services, which was a specific dedicated service to meet the needs of looked after children. And in doing so, I just created a therapeutic model, and a service delivery model, and then basically said, look, if you want decent quality therapeutic services for children for your care home, buy us and we will roll that out for you. And it was funded by local authorities and so mainly local authorities, occasionally NHS trusts, but mostly local authorities would pay us to support homes. So we've been doing that for 10 years now. That kind of is the bulk of my work. Although I'm trying to move away from that a bit. But
how's that going? How big's the team?
We've got 9 in the team now. So it's going very well in some respects. Depends how you define well, doesn't it? It's well in terms of proof of concept. Our model has been it works really well. We do collect outcomes, and it's really interesting. Another one of these sort of bizarre just quirks of fate really is that I found out about 3 weeks before NHS England trial was starting, or called the Youth Intensive Psychological Practitioner Pilot, which was a new NHS England pilot, which said, let's train assistant psychologists, because there's loads of them, to work in complex settings. And as long as they're well supported by senior psychologists, they should be able to do a good job in formulation-driven care. So that is not what assistant psychologists used to do. Assistants are seen as unclinical, so preclinical. So they write up notes, or they attend meetings and take the minutes, or they score up psychometric measures, or they administer psychometric measures, but they don't interpret them. So it's quite a restricted role, really. We've always used, within Aspire, we've used assistant psychologists a lot more creatively than that. And they do work within the care homes, and they are the point of contact between us, the seniors who formulate, and the frontline staff. So we recognised 10 years ago that the most important ingredient for good quality care in a children's home and in any complex care setting is the quality of the day-to-day care by frontline staff, because that's 24 hours a day, 7 days a week, up against 1 hour a week of therapy. Therapy is absolutely not the priority. It is the quality of those 24 hours, across those 7 days. So that's always been our model. It's been about empowering frontline staff to work in a psychologically formed, trauma-informed, attachment-focused, empathic way, and to be opportunistic with intervention. So you don't intervene once a week on a Tuesday afternoon at 2 o'clock. You intervene opportunistically throughout the week whenever the child is behaving in a way that needs some direct intervention there and then. And we've done that for 10 years, and it works really well. And NHS England thought, wouldn't that be a great idea if we had these roles in complex care settings? And I read about it and said, that is literally exactly what we're doing. So I rang up the guy that was lead coordinator at NHS England, who's coordinating the project, and said, you don't have LAC in your pilot, and this model is perfect for LAC, so that's an omission. You need to kind of find an NHS LAC service to join you. And also, could we join your pilot? And I know we're a dependent sector, but they interviewed us fairly rigorously to say, why should we be funding an independent sector service to join an NHS England pilot? And initially they said that they would only include us if we could find an NHS trust to join, so that we kind of were sponsored by an NHS trust. But there's no way an NHS trust is going to be able to mobilise in 3 weeks to get everything ready. So in the end, we said, well, we really want to do it. We can't find a trust. Will you have us on your own? And they said yes. So we were in the pilot from 23 to 24. It's just published in the summer. Really good outcomes. And now, finally, Aspire, this model, the spiral model, is of interest because I'm presenting all over the place on what to do with LAC. So there are conferences and there are working groups that are, commissioners from around the place. So in that respect, it's going well. So it's going well, proof of concept wise. It's going well, beginning to gain some traction among the people that matter, because I just want a model that works to be out there for the whole NHS. There's no proprietary stuff. I'm happy to give everybody it and say, here, have it. This is what you do. Here's my book. I've written the manual. I can't hold the manual up because it's downstairs, but here's the manual of how to set up and organize and deliver services for children in complex settings. Do it.
I love it. It feels your approach feels very real world, very pragmatic, very much like, no, we've got to include the whole scope here. We can't just be sitting in our ivory towers.
Yeah.
And I love that. I love that. That totally makes sense. So let's find out. Look, all this experience, all this knowledge, CBT and DBT and all your work there, then why do you choose to study hypnotherapy? And then why at our place?
Okay, well, I mean, this has been an interesting journey. So alongside the Aspire work, I mean, I keep saying alongside lots of things, I do lots of things because I always do lots of things. It was emotionally overwhelming to work exclusively, as I ended up doing, because of just the level of experience that I had. I wrote the Greater Manchester Crisis Care Pathway, so I was working with lots and lots and lots of kids in crisis, and then I was working for LAC, because I maintained my NHS role alongside the Aspire job as well. So my work was all children in crisis, and it was just overwhelming emotionally, and I was just feeling really burnt out. And I thought I need to do something a bit more fun alongside crisis, children in crisis, families in crisis. So, and I'm an equestrian. I event and show jump. I've got my own horses. I've been obsessed with horses my entire life. And I'd used psychological approaches, but for self-help, to overcome my own. I'd had a rotational fall, got quite badly injured, didn't jump for 5 years, and then kind of got back into it. So I decided that I was going to do some, basically, more vocational stuff. I wanted to work with riders who were scared, nervous, to get back on the horses. And so I set up Aspire Equestrian during COVID, so 2020-ish, I guess. I haven't looked it up exactly when I registered the company, and started working in rider confidence and mindset for performance. And people kept saying, do you do hypnotherapy? And I kept thinking, well, no, because, I know it's not a protected title and that I could probably read a book and go, yeah, I can try, but I don't do that. Like I've said before, I do things properly if I'm going to do them. If I'm going to do it, I'll do it with rigor. So my initial motivation, I'm sorry to say, Mark, was just so I could say yes. I didn't think it was going to add much to what I offered. I just thought, I didn't know anything about it. I just thought, well, this must be, it's just kind of like the stuff I do already. It's
You must have come
visualization,
across it with
positive
Alan
thinking.
Carr, because Alan Carr has his hypnotherapy in there as well, doesn't he?
Yeah, I mean, I just thought I was familiar-ish with, affirmations and positive thinking and visualizations and even, imaginal exposure. So I kind of thought, oh, it'll be a bit like that, but just done up in an airy fair, in a kind of, this is really special and different way. I kind of thought it was a bit like homeopathy for therapists, it's the drama and the mystique around it was the thing that made it work. And I kind of thought, well, I can, I'd like to do some of it so I can at least say without keeping my fingers crossed, yes, I offer hypnotherapy. But I didn't really, I didn't think it was going to be unhelpful. I would never do anything like homeopathy, which I don't believe has any evidence whatsoever. I thought it would add something to what I already offered, but I didn't really think it would add a huge amount, because I didn't know anything about it. I mean, bizarrely, the courses, I don't know if it's changed now, but when I did my doctorate in Manchester, it was never, ever mentioned as a psychotherapy. It was just simply wasn't part of the curriculum. I think if I'd asked about it, I would have been, even mindfulness back then was seen as a bit out there, because one of my research projects was on mindfulness, and the ethical approval department were like, you can't do that. That's, we're scientist practitioners. We don't do things like mindfulness. So yeah, that was my initial motivation, was just so I could say, yes, yes, I offer it to people who kept asking me if I did. So I then researched a few of the courses and found yours, among others, and was just really impressed at the very, very beginning for the all the things that matter to me, were, were being ticked. So scientist practitioner, focused on the evidence-based, rigorous, don't make it up as you go along, don't invent stuff, explain why it works, how it, myth busting about it. So the rigorousness of it impressed me, and the adherence to the evidence base impressed me. And the fact that it was a fairly lengthy course, you can just all, I mean, that was one course I looked at that I could have got their diploma, and I'm a graduate of the whatever college in a week or weekend or something, 3 days. Yeah, so I chose you.
And
So
how did that turn out?
Oh, well, I mean, this is the thing. I did it assuming it would just be a little bit of additional benefit to my sports psychology work. But yeah, no, it has completely surpassed expectations in terms of, well, firstly, hypnotherapy itself is far, far, far more effective than just being a bit of an add-on, do a script after a CBT intervention to consolidate some of the gains. It's just, I mean, I kind of hardly ever do CBT anymore because hypnotherapy just does it quicker and better. So for certainly for the client group I'm talking about anyway.
You mean
So
the riders, yeah?
riders, well, sports people,
Yeah.
but also, stress management and confidence and coping and, just, I mean, firstly, I was really quite humbled by the fact that I learned so much of the CBT side of things from it, because the course in Manchester seemed to have started with metacognitive therapy.
Oh.
Even Beckian therapy was seen as a bit old hat, and certainly behavioral activation wasn't seen as important. And there's a whole load of people that you taught me about who I'd never even heard of. Like Salter, for example. Where was Salter on the course? Didn't
Jacobson.
Jacobs, exactly. I mean, we learned, I think lecture one, module one, once upon a time they used to do behavior therapies, and then CBT came along and we didn't have to bother with them anymore. And yet, going back to looking at the stuff from the 40s and the 50s and the 60s and how rigorous it was and how effective it was and how evidence-based it was, I was thinking, I've never heard of these people. I mean, I'm vaguely in the dim recesses of my mind, vaguely familiar from lecture one, day one, 1995. But no, I mean, as I said slightly earlier in this call, I like to do things properly. So you should be really good at the stuff that you're doing. And I realized I'm not really good at the stuff I'm doing because there's huge gaps in my knowledge, which your course filled in, because we just didn't do behavior therapy. We started with CBT.
Yeah.
And CBT was a bit like, oh, well, you can do a bit of behavior stuff if you want to, alongside the cognitive stuff, which is the important stuff. But it was all kind of, this was when Adrian was writing his books and trying to get metacognitive therapy. Sorry, Adrian, I hope he doesn't see this. But it was like, don't bother with all that behavior stuff. It was just metacognitive therapy is where it's at. And it's like, no, it isn't. So yeah, the course, even the CBT side of the course, improved my knowledge and understanding,
Really?
but considerably, because I had so many gaps from my original training. And then the hypnotherapy side of it was just, I mean, I didn't know anything about hypnotherapy at all. If you'd asked me, what does it mean? What is it? I'd have said it's probably a placebo effecty thing where if someone feels very relaxed and then you tell them stuff and they believe it more because of the drama and the theatre around it.
Well, that's a theoretical perspective within the social cognitive approach as
Yeah,
well.
but you utilize that so much more effectively. Yeah, but I mean, part of it is the theatre of it, but it's also how the brain works.
Yeah.
So yeah, I mean, yeah, all the stuff about ideomotor responses, and didn't know any of that. How the brain body links, I knew a bit about from relaxation stuff, but I didn't really know anything about it. And the thing that I didn't know nothing about whatsoever was the experience of being hypnotized, because I'd never been hypnotized. I've never sought out hypnotherapy. It wasn't something I ever was interested in. So actually feeling what it feels like to be hypnotized is qualitatively completely different to the kind of in CBT, you might do some guided discovery, you might have some aha moments, brilliant. And in visualization or imaginal exposure, you might experience anxiety and then it habituates and you feel a bit better. Brilliant. That's experientially powerful. But it doesn't remotely compare to the experience of being in hypnosis and someone going skillfully taking you through, hypnotic script writing scenario where you are just there. Um, and it's utterly transformative, personally and professionally.
Just unpack that for people here in terms of what is kind of qualitatively different there in that when you're doing that as opposed to doing some imaginal rehearsal in CBT.
It's hard to kind of explain what the difference is, other than in CBT, you're in a room talking to a person. You're very clear about the fact that you are in a room talking to somebody else, and now you're doing this exercise in which you mentally rehearse something and you cope ahead, or you do a role play. But so you are play acting in CBT. You're role playing, or you're rehearsing, or you're coping ahead, or you're imagining coping. You're not doing it. You're just thinking about doing it and visualizing doing it and imagining doing it and pretending that you're doing it and rehearsing doing it. But that's sort of falling into it where during the experience of hypnosis, it's just qualitatively richer and more compelling and more transformative. I don't know what's happening, Brett. You tell me, Mark, what's happening in my
Well,
brain
I
that
don't know.
makes
I
it
think there are
different.
different. I think there are different ways of, one of the ways, and I've gone back to a number of reading a number of really interesting papers by this Australian psychologist, Yeats, who'd done about 6 different papers on James Braid. It was interesting to go back and look there because there's no expectancy when he was doing stuff. No one knew what the hell he was doing. So he's really working with, and this idea, particularly of the kind of a clearing of the mental space, and then this becoming kind of nearly expanded as a mental space, and then a single stream of idea instead of this sort of Brownian motion of chaotic bits and pieces here and vaguely moving in this direction. This is kind of completely cleared, expanded, and then just kind of one single idea now. This fixed attention on this dominant idea. And it was interesting, the first use of the term psychophysiology seems to be from James Braid, who proposed to call it, because there's all this idea that's dominating this enlarged mental space has then a connectivity into the physiology. So you've got, physiological, you've got other cognitive, you've got emotional stuff going off, and some of that actually bringing about some structural change as well as we know on the reverse side with IBS and things like that. So this idea of that, he's saying, how that psychophysiological thing actually works. We don't need to answer that because that's, of course, we got some ideas about that. But I think that idea of monoideism, of clearing the mental space, and then and he drew a diagram of something he'd taken from somewhere, I think from Lankoff, called the Imaginarium, of this sort of visual space here that's all cluttered and then becoming emptied and organized. And I don't know if does that
Yeah,
make sense?
it makes perfect sense.
Yeah.
It's a more vivid, more compelling, more more transformative experience than doing the
Yeah.
same sorts of things, but in as CBT exercises.
To come back to a bit of your Adrian Wells experience, one view of it also in cold control theory is that it's a reduction in metacognitive processes, so that you're having more primary, what psychoanalysts would call primary process, what Salter would call that initial excitatory response to stimuli without this reflected back. So you're not constantly going and being, and that's why sometimes you don't even remember what's happening because there's no higher order thinking going on, which can happen, I believe, not at the same time, but very, very quickly, rapidly becoming aware of them back into experiencing. But hypnosis is more just experiencing. So
Yeah,
it creates a stronger, more intense, less reflected upon, but more intense in experience. Does that make sense?
that makes perfect sense. Yes, I knew you'd be able to explain it to me.
I'm just these are just my different, and the other thing when I was talking with Stephen J. Lynn before he passed away was this idea of disinhibition, that people are that's part of that shutdown of the metacognitive, which is a little bit of a control process as well. They're just more they're more in it and less inhibited, and they respond also emotionally, therefore, and behaviorally more strongly, and more openly. And I think that's interesting, you know.
Yeah, I mean, one of the very first things that I did when I started doing the course was obviously I started doing the practice sessions. And every time I did a practice session, I would do something real, because what's the point in making something up? So
Mm.
it would generally be around horse riding. So it'd be like, I'm competing at the weekend and I want to feel better about it. And from day one, I started using that. I mean, I haven't competed since then. So we're talking a couple of years now without doing a self-hypnosis recording in my lorry before I get on the horse, because it is just absolutely one of the most important parts of my pre-competition routine now, is to record. It'll be about a 2 or 3 minute brief. So I'll do a longer one the day before, and I'll then record a 3 minute version to just get myself back into that
Nice. Yeah,
place
yeah, yeah.
where I'm
Mhm.
absolutely fired up and on it and mentally focused and ready to go. And I ride differently. So the proof's
You've
in the
been
pudding.
using it with yourself, and you've been using it with other riders that you work with now, yeah?
Yes, so I used it. I mean, the first thing I started doing was using it with myself, and then I started doing it with just riders that I was already working with, and then I started doing it in the camps that I run, because I do rider confidence camps, and discovered, because there's no way I could do a CBT intervention with 26 total strangers who turn up on a camp for a weekend, and I've got half an hour with each one. You know, there's not much you can do CBT
Mm.
wise with that. So although I'd always done kind of like a brief mindset confidence coaching kind of session with people where they just say, so what's getting in the way of you for you? And then would identify a few unhelpful beliefs, and would identify a few unhelpful behaviors, and would do a bit of relaxation stuff. Um, it was kind of okay. People liked it. It made a slight difference. But now I do hypnotic script writing with people, and it's completely different.
As a
They
as
do
a
it
as
and
a
they go
group,
amazing, and then they go and ride their horses, and they come back going, I can't believe what I've just been doing. All my
you can't be
horses
doing that as
haven't
a
got it up.
group. You can't do hypnotic script writing as a group, though, do you?
No, I do it one
You
to
do it
one. So the
one on
26
one.
people that come, they all have half an hour each.
Oh, they have half an hour each
That's
with
for
you. I
three
thought you got
days.
half an hour with the whole group. I was
No,
like,
it's half
that's
an hour each.
that's
So they
intense.
spend 5 minutes telling me what they want, how they want the lesson to feel, and then 25 minutes having a hypnotic script writing experience and then they go and have a lesson like that. So I mean, that just is completely impossible in CBT world to do something as quickly as that, as effectively as that, that is as transformative as that. So that was good. But then I kind of thought, well, I only ever was interested in hypnotherapy for horse riders, and it was only a marketing ploy to start with.
Mm.
So I could say, yes, I'm a hypnotherapist. But then I started thinking, well, actually, a lot of this stuff is really applicable to the children in care, because as I kind of explained earlier, my model isn't really based around therapy. It's based around opportunistic intervention in the moment when children need something. And some of these interventions, particularly, I set my staff originally on the Don Meichenbaum stress inoculation training, because I thought, oh, these kids, they have no resilience, they have no skills, they have no
Yeah,
coping.
yeah, yeah, yeah.
Actually, the staff don't much either. So, they're stressed and struggling. So they did that. A couple of my staff members went on that training, and then I thought, just do it properly, like do things properly. Two of my team are now doing the full diploma, with the aim of then doing some intervention within the care homes with the children around relaxation and calm. Because these kids all live in a state of heightened fight and flight. They're traumatized, they're abused kids. That's why they're in care. But it's so they are reactive, they're stressed, they're hyper aroused. Um, and so the aim for Becky and Brandon, who are on the course, is that they will then do a lot of the de-arousal stuff, the relaxation stuff, and maybe kind of try and feed Salter in there a bit as well for self, for a bit more, because these kids are so vulnerable and so unsure, and
Yeah, yeah.
they need some self-esteem work, and they need to be a bit more willing to, you know, stand up for themselves and be
Like
the
bit of that,
excitation stuff,
bit of the ego strength thing. I mean, this sort
ego
of strength
strengthening. Yeah,
space. I mean, emotional self-regulation, as you know, as we teach, as being, I think, so fundamental to building self-efficacy. If you can't regulate your
yeah,
attention and and any aspect of your behavior, you're out of control, and your environment's going to control you. So,
yeah.
to me, as Bandira said, that's the first step, to do with, and for a client to get that and be using it, I think is like, now we can get some progress up there. Otherwise, they're just going to be flinging around with whatever's happening, essentially.
Yeah,
So
I mean, these kids are so reactive, and yeah, emotional regulation and coping better is very much up. So I'm really excited to see where that goes. And they haven't finished the course yet, so we have to kind of wait and see. I don't have time to go into the homes. That I don't work directly into the children's homes anymore. So I haven't done that yet, but that's the plan. We have, I mean, we had already got a work program kind of in development called Project Brain Health, which was around this predated hypnotherapy, but it was around things like gratitude and laughing, and so serotonin on a plate, eat properly, sleep hygiene, that all that kind of reducing vulnerability factors at a very basic level. So Project Brain Health was about making sure that you feel there's something rewarding happening to you each day, making sure you achieve something each day. And sometimes with these kids, they are achieving a lot, but they don't notice. So it's directing their attention to achievements, and spending time in nature, some mindfulness work. But the hypnotherapy, I think, is going to fit into Project Brain Health really, really well.
in terms of reinforcing and strongly experiencing those different aspects.
Yes, and
Yeah.
also I guess part of the vagus nerve lecture, the kind of parasympathetic nervous system arousal and de-stressing the sympathetic nervous system.
Yes, you did pick us up on it on some elements
Sorry.
of the lecture.
That was my first comment, and I was a bit like,
I was
how can
like,
they get something
well,
so obvious wrong? And I'm just gonna
who's
tell
who's
them.
who's this? Who's this? Who's coming in? And I hadn't, I mean, some of those were recorded a while ago, and that time I was like, oh, that's, so but interesting. Just that this was about, I believe it was about some they polyvagal. But I'm surprised I'd left that in there because I'd always been skeptical about it, or whether
Well,
someone
it was
else had done.
polyvagal theory was the thing that was a bit kind of, I don't, about that being linked to autism, but also
Ah, yes, yeah.
getting them mixed up between the vagal nerve activating the sympathetic nervous system. And I was like,
Oh,
okay,
well,
polyvagal theory, I'm dubious about, and I'd have let that lie if that was on its own. But if it was that mixed in with
yes, the
you
big
want
day.
to activate your sympathetic, and it's like they've got the systems the wrong way around, and that's a bit of an error. So,
I think the first
so I
teacher
did point that out. Sorry, go on.
we fixed that a little bit there. But the polyvagal thing is interesting because, as I said, I've been, well, let's not go down the whole pop trauma route and discuss that. But because it's, this term has expanded and I think become
Yeah.
quite problematic. I consider it sometimes kind of nearly iatrogenic in terms of instead of focusing on resilience, and
Mm.
but this yeah, of course, I'm in discussions. Hopefully, we'll get a webinar with him sometime. But he's a bit shy. Dr. Paul Grossman over at Basel
Right.
University, who's been publishing now sort of against polyvagal theory pretty rigorously. I don't know if you read some of his latest stuff.
No,
Oh, you
no.
should have a look. I mean, I'm surprised these people that have developed all this vagus nerve technology, neurosimunuria, haven't actually tried to take him out with. He's basically said there's no kind of overall vagus nerve. It's very organ specific, actually. And even then, I mean, it's quite. I'll send you the paper.
I'll have a
It's
look.
yeah, he's a very very good guy, very sound, but a little bit shy. But there again, puts a huge project up on ResearchGate. It's had over 100,000 views now about
Oh wow.
polyvagal. Have you
Okay.
not seen that? Oh,
No.
it's yeah. He said, "Is there any support for the three premises of polyvagal theory?" He asked that in 2016. It's now had over 100,000 views, and nobody's come forward with anything to support it. Um, but fantastic. So, what would you? I'm just having a look here. Yeah, you've got two colleagues there already doing. How are they doing through the course now?
Well, I think they're still in stage what maybe we've moved on to stage two. I don't know. They're busy, unfortunately. One of them's also doing a doctorate in counselling psychology at university at the same time as doing the hypnotherapy course. And the other one's doing a master's I can't remember exactly what the title of her course is, but I'm big on CPD, so all of my staff get funded to do. I believe in growing my own staff and
Brilliant
keeping them
stuff.
forever.
Fantastic. Well, good for
So
you.
so they're
We're
really,
very
really
happy
busy, but
with
they're
that.
loving the course. They're really, really
Good.
enjoying it. Yeah.
So, what about some advice for people out there who, I mean, people are going, well, should I do a psychology degree? Of course, then you come out and go, well, what can I do with that now? So that's interesting. Then after that, should they, counseling, clinical psychology, counseling psychology, a psychotherapy course, A hypnotherapy course. I mean, what would some of the advice you'd be to some people who are trying to make some decisions there on their sort of professional pathway to getting into some sort of therapeutic work with people?
Okay, well, I think the pathways are problematic. So clinical psychology first. I think there's a massive, massive problem with the fact that there is a huge bottleneck. I mean, literally hundreds and hundreds of applicants every year for each place.
Mm.
So, and there's also hundreds of applicants for assistant psychology posts within the NHS, so paid assistant psychology posts, which is a prerequisite for the psychology courses. So these posts can be quite exploitive, I think, because they're highly, firstly, you have to have an undergraduate degree in psychology with minimum 2-1. So a lot of people go on to do a master's in psychology to make them more appointable, but the master's itself, unless you do a vocational master's in something, the actual academic master's in psychology gives you nothing. It's not a qualification. So essentially, to work in the NHS, you need to either have a core qualification, core mental health qualification. So that's social work, nursing, or clinical psychology. That's kind of it, really. So you have to have a core
Occupational
qualification.
psych, physio.
Possibly, yeah, ed psychs, occupational psychologies. There's two routes to working in the NHS. One is that you're listed on the HCPC register. So that would include OTs, EPs, forensic psychologists, and the like, and also play therapists, art therapists. So it seems really random as to which therapies, because CBT is not on there, play therapy is. I would argue that CBT is a lot more rigorous and a lot more evidence-based than play therapy. But anyway, play therapists are there, art therapists are there, CBT therapists are not there. So a core mental health qualification tends to be social work, nursing, psychology, clinical psychology. If you haven't got that, then even with a master's and 10 years experience as an assistant working, extremely high levels of skill, you still can't get anywhere. You still can't do anything in the NHS, which is why there's a big shift to private work. A lot of people actually, even now, I mean, clinical psychologists spend so long training, getting onto the course in the first place, that they feel that they've psychologically, it's kind of created a scenario where they feel they've paid their NHS dues before they've even started the course, because they've spent years and years and years trying to get on the course in the first place. So once they qualify, they're like, well, I'm not going to go and work for an underworked, an overworked, under-resourced, stressful NHS job when I can just go and set up private practice. And some courses are even doing modules now in setting up a business, in which, and this is an NHS funded course, so it strikes me as bizarre. So clinical psychology is problematic. Both of my colleagues who are doing the hypnotherapy course and also other training, they haven't been able to get on the doctorate for clinical psychology. So instead, they're getting onto a different doctorate that probably is less useful for what they end up wanting to do, what they want to do in the end, but just gives them that tick in the right box.
Is that the counselling psychology?
Counselling psychology, yeah. I'm sure they'll learn useful things, particularly for children in care who are very distressed. And but in terms of the rigorousness of what we do in Aspire, we offer an eclectic range of extremely rigorous evidence-based therapies, which we do blend sometimes, but only if we can do them really well first on their own. So it's, yeah, I mean, the in-house training is going to be more useful generally than some of these courses, but sometimes it's just a means to an end. You do, one of my former staff members who's now left did the art therapy because that was HCPC approved, which meant that as soon as she had that, then she was an HCPC professional. She never used she didn't use any of her training at all ever the day she qualified, because it wasn't useful for what she was doing. I mean, it may well be useful in other jobs in the future. I'm not dissing art therapy, but it wasn't useful for the job she had with me. I mean, it was vaguely useful occasionally, but it wasn't really.
It's a problem, isn't it? My daughter's just done her master's in cognitive neuroscience at UCL, and because she's literally thinking of going to do physics because she wants to work very much kind of across all, and with, she's working with stroke victims. She's thinking of doing physiotherapy, but everyone's like, oh, physiotherapy, but
so yeah, I mean, I don't think the pathways are right at all for work coming in. So I mean, in the end, it makes much more sense to set up privately, because you can do what you want then, and you can say what you do, and if people want what you do, which in the case of hypnotherapy is very popular, quite rightly so, because it's incredibly effective in helping people, and CBT as well. As a CBT therapist, if you haven't got a core qualification in the first place, you still have nothing. that gives you. I mean, you can get a CBT job if you can find one, but specific CBT jobs within the NHS are really hard. Generally, the inclusion criteria does say you still have to have a core qualification first. So, and CBT isn't on the list of HCPC approved professions. So yeah, I mean, my advice is just be aware that doing the psychology undergraduate degree and masters, they're interesting, and you have to do the undergraduate degree if you want to be a clinical psychologist, but the masters doesn't actually get you much further. So do it if you're interested in doing it, if you're interested in research, if you're interested in, then go ahead and do that, but don't do it as a means to an end, because it probably won't get you where you want it to.
And even for private work, they're not that vocationally focused in terms of kind of skills and knowledge for the therapy room.
Yeah, no, I mean, once you come out of academia, you then have to learn the whole therapy side. The undergraduate psychology degree doesn't really equip you for any form of therapeutic work at all. Certainly not the course I
We had a
did.
clinical psychologist in Italy take the course. One of the first people who did it when we did it online, 3 years undergraduate, 5 years in clinical psychology. He said, I barely know what to do with people though. And I learned so many things. And I was able to help somebody's fear of flying over the phone
Yeah,
using
amazing.
your approach, you know. So interesting.
Okay, well, someone say they've got an MSc, which is brilliant.
Yeah,
I'm glad you found it helpful, but I'm not saying the knowledge isn't useful, but just in terms of a route to something else, it
yeah.
doesn't necessarily give you much higher chance to get an assistant job, and it certainly doesn't give you it doesn't meet criteria for the NHS mental health practitioner jobs. I'm not in any way, I'm not suggesting that the MSc isn't useful. And I guess if you do, you could do a clinically focused MSc, but some of them are academic. And research is really important, and I think more people should do research. And I think having a solid knowledge of research is incredibly useful in terms of being able to appraise the value of what you're reading. Where does it come from? Who's written it? What are the confounding variables? Because a lot of what you read is, you can just tell straight away if you have a research background that it's not valid, it's not useful. So I think I'm
So
not
that
saying it's not useful. I'm just saying it's not necessarily a passport to other things.
I'm hoping our course has this inbuilt aspect to it that you develop, which is somewhat like that, which I call developing a good bullshit meter. Which but I'm also thinking we may need to, I think we might do it. We'll speak to you about doing a module on about being an evidence-based practitioner, which is kind of drawing some of that together, but in a more focused way. But speak a little bit to that, perhaps, because one of the things Don Meichenbaum says in one of the places he's interviewed, and somebody says to him, what do you think is the hardest thing for a psychotherapist today? And he says, avoiding the bullshit.
Well, yeah, I mean, there's a lot of it about. And I think, students in particular are hungry for knowledge. That's why they're on a course like this. And if somebody comes along and says, I've got this fantastic booklet all about this, do you want to read it for free? Everyone's going to go, yes, yes, send it to me. And it's like, well, hang on, you've got a finite number of hours in a day to read stuff. And so you have to be discerning about what you choose to spend your time reading. And don't just read what's available, read what's useful. Because quite often the people that are giving you resources away for free, giving them away for free for their own reasons. And also, they're giving it for free because nobody's prepared to buy it. So they're trying to give resources away. I mean, I give resources away for free too, but for
All
other
right, well, let's
reasons.
not comment about that particular episode where we had on our
But,
member. Tony
it's
was giving
that.
away a book for free, and then it turns out it was.
But people read stuff and just think that's really interesting. There was something I read, and I can't remember in the context I read it recently, but it was basically, premarital sex is bad for marriages because 5% of people who don't have premarital sex get divorced compared to something like 50% in the general population. So obviously it's a really, really bad idea to have premarital sex. And I was thinking, well, okay, I mean, surely most people reading that would go, well, if you are among the vanishingly small group of people who don't have premarital sex, it's probably on religious grounds. And if you are not having sex on religious grounds, you're probably not allowed to get divorced. So unless you could control for, is divorce permitted within the tradition which you clearly devoutly follow because you have obeyed that particular rule, it's meaningless, utterly meaningless. But people read it and go, wow, that's pretty interesting. So yeah, I think it is really, really useful to know to be able to read with a critical eye.
I think
Um,
science journalism is should be a proper profession out there.
well, yeah, I mean, if anyone's read Bad Science,
Yeah.
you will see. I mean, it's a fantastic book, and I recommend anyone who's interested in this being working as a scientist practitioner to read it. Because it's, I mean, it's hilarious, it's funny, it's easy to read, but it's infuriating about how bad science journalism is. Um,
By Ben Goldacre. I got it for my
yes,
daughter when
Bad
she was
Science by
12.
Ben Goldacre. It's
She
brilliant.
she loved it. And everything we then I would be talking about, she'd go, "Isn't that just the placebo? Isn't that just the placebo?"
Yes, I mean he takes aim at Gillian McKeith
Yeah.
and the nutritionist because that's a whole area of complete bullshit nonsense because it's not a protected title. Anyone can do it. You can be Gillian McKeith.
Formerly Dr. Gillian McKeith.
Formerly Dr. Gillian McKeith.
I will let you know out here that the former and the founder of the college, Donald Robertson, was the person instrumental in outing her fake PhD with a
Did
complete.
she? Really?
Yeah,
Oh
he
wow,
wrote
fantastic.
the ASA about it. Yes.
But yeah, I mean, but also the press and how badly they cover science stories.
Mm.
Um, so yeah, I mean, there's a lot of not being able to discern the value of what you're reading about, and there's an awful lot of pop psychology about, and there's a lot of people who want their particular. I don't believe anyone ever really reinvents anything. I mean, yes, that's not true. There are people. I personally have never reinvented anything. I've never created a new therapy.
Because
I think
Adrian
I'm
Wells is going to sue you before you know it, if you say that.
I've never invented anything, but I think I am quite good at figuring out what's useful and
Mm,
what's worthwhile and blending things and
mm,
taking good bits and putting them together.
mm.
But true pioneers in the field of mental health are rare. And when they come along and there's a genuine advance in something, then it gets really well researched. And then lots of people try and replicate because it's exciting and interesting. And then there's all of a sudden there's hundreds and thousands of papers and lots of citations and it's everywhere. So if you're someone who has, five something theory. I won't name a particular one actually, but you've created the new 10 pillars of success or whatever, and it's a brand new wavelength of light that you shine in your eyes, and then you listen to this wave, whatever. You've created something brand new, but it's all proprietary. You have to pay, you have to go on the course, and only you could train it. And unless you've got your level 3 blibble flobble therapy, then you're not a flibble flobble therapist. That kind of stuff makes my teeth itch because it's like, no, if it was good, it would be everywhere. And if it's not good, you wouldn't need, but people make their careers out of creating or pretending that they're creating new treatments. So if you actually, some of the ones that are a bit more established, if you actually look at what they're doing, it is just CBT packaged in a different way, or it's motivational work, and why not just credit the people who invented it in the first place and say, this is a really useful thing which blends these things. Why
Well,
do you
that's
have to
something
kind
we
of,
try and I think we try and do. What
yeah, yeah, I think you do,
my
absolutely.
business coach gets a little bit. He says you've got to put your name to a few things you're doing here. Stop giving quite so much credence everywhere. But I think provenance is important. People
It
can
is,
see the
definitely.
origins and then they can understand the mechanisms, and we're not reinventing stuff.
Yeah, no, I agree. I mean, I think that you can own something that's a clever blend. I mean, Marsha Linehan herself at DBT said she didn't invent anything.
Mm. Mm.
She looked at all the different therapies that are out there and just put together the bits that those kids, or those adults actually, as it was when she started the therapy. It's just behavioral science with Zen wisdom, basically. I mean, that's the two things that come together in DBT. But she didn't invent anything completely brand new. And she cites everybody else for the behavioral science stuff and all the Zen masters for the Zen wisdom stuff. Um,
Well, I
yeah,
love that. When Samuel Johnson was given this manuscript to review, the great British guy that created our dictionaries, and he said this manuscript is both good and original.
yeah,
Unfortunately, what is good is not original, and what is
unfortunately,
original is not good. And I
yes,
think Richard McNally rephrased that about psychotherapy as well, and said, and it's so true. It's so true.
yeah,
So I think that thorough grounding in the end, I feel in fundamental mechanisms is where I want sort of people to be at. But
yeah.
yeah. So let's just we've got a few minutes left here. Let's talk about what somebody said here. How do you treat people who stopped smoking years ago? Oh, sorry, it's moved there. Because of a relapse because of emotional event.
Right, okay.
Sorry,
Let's
switch.
rewind a little bit.
Yeah,
So smoking cessation. I did the PhD in smoking. I compared Alan with
yeah.
NHS. It didn't. It worked okay. I then developed my own protocol. Um, I ran
I
treatment
couldn't find your
groups.
book. Yeah, I have you sent me your book, and I was looking for it before this, but I couldn't find it. There we are. Yeah,
But the paper, I wrote the paper first.
and I have that too.
So back in, God, when was this? 2007. So I did the PhD in 98, ran the groups for a while, did a research study, and came up with when we wrote the protocol up, that actually had better quit rates than either Alan or the previous work. So I was happy with that. I can't remember exactly off the top of my head. I think it was 35 at 42 weeks or something. 30, 30% still not smoking at 1 year follow-up,
At what
which is
1 year
pretty good.
follow-up for a randomized control trial where people aren't paying.
No,
Um,
yeah, NHS intention to treat, GP referred,
yeah, that's good.
30% at 1 year follow-up. So anyone lost to follow-up was counted as a failure. So those were 30% of people. We were quite good at tracking them all down. So after running groups for several years, I thought, I'm bored of this. I'm going to write it all up in a book, and then the people can read it to the heart's content. And so, well, the book's no longer in print, sadly, because it kind of it was critically reasonably successful, but it bombed sales wise. So the first 5,000 print run, they all sold out. The 5,000, there wasn't remainder, at least. I was spared that indignity. But the 5,000 copies have been sold, and it's available online on Amazon secondhand. But it is fundamentally, I think, again, I didn't invent anything. I took the best bits of Car and I ditched all the self-aggrandizing nonsense from Car, and I took the best bits from the NHS work, which is NRT. NRT works. The evidence is clear that NRT works, and also habit, and because Carter says habits, nonsense, worry about habit. So that was the kind of three bits really. It was habitual smoking, as a kind of habit disorder, really, and the cognitive shift was the big thing though, which makes this approach and Carr's approach different from standard treatments, which focus very much on the idea that giving up smoking means giving up something of value. That the fundamental premise is that I mean, my PhD actually was a randomized control trial in the end, but it started with do people have positive beliefs about smoking? Answer yes, not surprisingly. Are those beliefs modifiable? Also yes, not surprisingly. But a bit more surprisingly, because a lot of researchers thought, well, these beliefs aren't beliefs, these are realities. Smoking does help you concentrate, smoking does help you relax, smoking does help you cope with distress, smoking does help you feel more socially confident. And it's like, no, it doesn't. You just think it does for various reasons, which we haven't got time to go into. But those beliefs are not, they are beliefs that arise out of what in Carr and I both describe as a fundamental misconception about how nicotine addiction works. In that you have a cigarette, you immediately feel fantastic because the nicotine itch, the stress has built up over time since you stubbed out the last cigarette, and you have it, and all of a sudden you've restored yourself to factory settings, which is a place of being reasonably okay, until you start withdrawing from nicotine again gradually and the stress levels increase again. And so you have to keep smoking just to get yourself back to where you would be if you'd never smoked a cigarette in the first place. So the very short answer to how do you help someone who has had an emotional problem and started smoking again is the whole question misses the point. They believe, I don't mean you miss the point of asking the question. I mean the person who says, how do I stop? The client who is asking that question has missed the point that smoking doesn't help them. It didn't then, it doesn't now. But they probably quit believing that those benefits were real. And so they had to use willpower and self-denial, and then eventually got used to it and coped. But they kept thinking, oh, you know, every so often I could really do with one. Every so often I really could do with that little extra thing that smoking used to give me and I don't have anymore. And recognizing you never had anything good from smoking, that those benefits were illusions.
Yeah.
So when you give up, you don't believe that you, so when you have an emotional distress now, smoking isn't something you would ever reach for because it didn't do anything then, and it certainly won't do anything now when you're not even addicted to nicotine. So the person probably quit in the wrong way in the first place, and now they need to quit properly with a proper understanding of the cognitive side of smoking cessation. Is that adequate answer, Mark, for someone who hasn't
That's
done
a good
the
answer. That's a good answer. And
17 years since my last
it very
client.
much
That's what I would say.
also with, you know, that I think my feeling with the Alan Carr method a little bit was it's a little bit too nicotine withdrawal focused, because I focus also on nicotine as being a sympathetomimetic, and that so I say you're having a cigarette and kind of you don't realize your engine is revving because there's some nice music playing, which is the dopamine or whatever, but who knows what that is. But you've got that, oh, everything feels like all the problems have gone away. But actually your engine's revving, and as soon as the music finishes, which is not long afterwards, you're left all like a bit more agitated. That's not just a withdrawal of the nicotine, it's actually it's the heart rate being, so we focus in on that
Yeah,
a lot more. And then as basically, so your brain thinks the way to cope with stress is having a cigarette. And so unless we actually solve that and realize
yeah,
that it doesn't, it created that stress in the first place. So it's not just
yeah,
nicotine withdrawal, it's the sort of stress response. But that's essentially our model, particularly, and then getting
yeah,
in absolutely hammering that idea really strongly.
yeah. And that
So
was what the intervention was in my trial,
yeah,
actually, was um, just that cognitive shift. Cigarettes do nothing for you.
yeah,
And you can almost see the penny drop. I mean, I could predict people who were going to successfully quit based on their feedback forms. Because when if they said things like, it was really nice to have someone to talk to who understood the difficulties, I'd be like, no, they're not going to quit. If I had someone that goes, oh my God, I had no idea how cigarettes work, thank you. I was like, yes, they've got it. They'll be
yeah,
fine.
yeah, yeah, yeah.
So yeah, I mean, even back then, I'd be interested to talk more at another time about this effect you're talking about. But yeah, we recognise that smokers are more stressed. That nicotine is a stimulant. It gets you agitated. It raises your heart rate, and it's depressing to be a smoker as well because you have to. It's distracting.
Well, we
It's
know from the research
frustrating.
that it makes people slightly depressed and anxious. You know, and
Yes,
that is
absolutely. Yeah, like alcohol.
the meta-analysis on that. And the other
Yeah,
thing I think is the smokers often, though in other domains they may have good self-efficacy, in the aspect of stress and emotional self-regulation, they do not. So that they actually just haven't learned how to cope with. We're back to the whole emotional self-regulation. So I do believe a little bit like, teaching them some emotional self-regulation skills
yeah,
because they haven't developed any very often. I mean, I've
yeah,
had people, directors of businesses, breaking down in tears in the session, terrified at the idea of stopping smoking because how will I deal with the feelings?
yeah, yeah. Oh, yeah. I mean, it's a powerful nut to crack if you don't do it the right way. And people are terrified, utterly
Yeah,
terrified.
utterly terrified. Fascinating. So let's just take 2 or 3 minutes quickly on vaping. What do you think? Isn't this the solution? Don't you think?
No. Oh, vaping is I am so cross about vaping because I'm old enough. I was working in the smoking field when vaping developed in the first place. Um, and it was so obvious from the very, 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 very beginning of vaping that this was not being marketed as a smoking cessation aid. It was being marketed as an alternative to smoking because of the flavors and the market. If it was being marketed as a smoking cessation aid, it would have been in the chemist next to the Nicorettes. There already was the inhalator was a nicotine replacement therapy, an NRT vape essentially, but it was packaged plainly and it was in the chemist. It wasn't sold in head shops along with CBD oils and tattoos. So it was really obvious that this was something new, being marketed very, very specifically to children. Um, and I remember shouting at the television when I was watching breakfast TV when there was a government minister saying there's no evidence whatsoever that anyone ever takes up vaping. It's only used as an alternative to smoking. And it was like, not yet. Give it a few years. You can see where the money's going. You can see where the marketing's going. You can see where this is headed. And I mean, vapes are just highly, 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 highly strong nicotine replacement therapies. If it's nicotine replacement therapy, they are so strong. The amount of nicotine you get in a vape is very, very strong. So obviously, someone who vapes is going to get addicted very, very quickly. And then once you're addicted to a vape, you are no better off than being addicted to a cigarette from a psychological point of view. Maybe some health benefits, I don't know. Vaping hasn't been around for long enough to really know what the long-term health benefits might be of vaping. I can't imagine it's massively good for you to be inhaling huge amounts of nicotine and vapor filled with chemicals every
Well,
day. But
we know the impact of nicotine. Well, this is interesting because the impact of smoking on mental health in terms of increasing anxiety and lowering mood is, I think, fairly clear now. I
yeah,
personally think when we look back in some time, we'll see all these people with mental health disorders who smoke so much, we're going to go, that was not a good idea. But anyway,
Yes.
because I think it makes it worse. It's temporarily better, but long term worse. The idea then that, well, is that to do the other substances, or I think is to do with the nicotine, because the nicotine's
Yeah.
a sympathetomimetic. So now we've got a
Absolutely.
whole bunch of people addicted to nicotine. My understanding is after a week, nicotinic receptors multiply threefold in the brain after a week of being regularly exposed to nicotine. So they've got all running around with a whole bunch of extra nicotinic receptors now,
Yeah.
high dose. I mean, and then when they
But
can't
also
get it, they can't cope. They're going to
the thing
be.
that infuriates me most about vaping is that at the very least with cigarettes, although cigarette smoking is a bad thing, there was an inbuilt inhibitor because smoking is horrible. So, and it makes you throw up if you are new to it. So if you are 10 years old and your big brother nicks your mum's cigarettes and gives you a puff on a cigarette, you are going to limit your intake. You won't inhale, you will try very hard to smoke very little. And really, you don't get, certainly not in the UK anyway, you don't get very young children smoking cigarettes. A, because as soon as they have one, they think that is disgusting. So they might pretend to like it for a little while, but nobody likes their first cigarette. Like nobody likes their very first cigarette. Um, Most people don't like their first few, it's peer pressure, and that tends to be a bit later. But vaping's not the same. You have a cherry flavored vape or a bubblegum flavored vape. You can get very young kids starting to vape and thinking, oh, this is all right, quite like this, and getting addicted much, much, much younger than was the case for cigarettes.
So if this
Um,
addiction means then but an increase in anxiety and lowering of mood, lowered self-efficacy in terms of self-regulation and coping
yeah,
with stress,
yeah,
what are we setting ourselves up for?
yeah. I mean, I think vaping is going to be the health scandal of the next 50 years. That it was entirely self-made. It did never had to happen. If vapes were never permitted to be sold anywhere other than chemists, they would have been a commercial failure and they would have just disappeared long ago because the inhalator was never any more successful than the gum or the patches. Um, or
And by
the,
that, you're not saying just the impact, maybe we'll find that inhaling this stuff, makes your lungs collapse, which I think it does to some extent, but actually in terms of mental health.
oh, definitely, definitely. There are so many children who vape because it's cool, because it's marketed to children. The flavors are childish, child friendly, I should say. Bubblegum, candy floss, black cherry,
So we're going to have a bunch of
purple
children
grape.
who are more anxious, more depressed, dependent on their vapes, can't cope without them, and
Yeah,
have got lowered. It's interesting because when I work with smokers, one of the things they go, I hate myself that I can't cope without it.
yeah.
That's one of the things they
Oh
have.
yeah, it totally ruins your self-confidence that you're,
Yeah,
you
yeah,
are, and it just gets in the way. I mean, you can't sit through a film without kind of wanting to nip out to the foyer for a quick puff before you come back in here because it just gets in the way of everything.
yeah.
Um, and
All
that
right,
that makes you
well,
feel bad about yourself.
yeah.
So yeah, vaping infuriates me because it just didn't need to happen. It was so predictable, and in fact, it was predicted. I mean, there were lots and lots of people who were saying what I'm saying now back then, but for whatever reason, either incompetence or, if you were cynical, tax revenues reasons, they nobody was listening. I don't believe government ministers in the health department are stupid. So if it was so obvious what was going to happen, if this was allowed to be aggressively marketed on every high street in the country with flavors deliberately designed to be attractive to children, um, that was blindingly obvious. Why was it allowed to happen?
My view is that some of the senior advisors, psychologists or psychiatrists who are so-called tobacco experts actually don't really grok the nicotine issue. That's my
Yeah,
view.
maybe they are. Maybe they just didn't understand it well enough.
I'm not going to
But
name
it was
I'm not going to
so
name
obvious.
names, but I don't think they really grokked the why nicotine is so addictive.
Yeah,
And it's not the chemical side. It's not just the chemical side. It's I say to people, it's an emotional affair. It is an emotional affair. It's
yeah,
like a toxic lover. That's how
yes,
I characterize it, you see. Who says, "Oh, come and be with me," but then leave you feeling shit afterwards and they've taken away your health and money. And you
yeah, absolutely. Well, yeah, nicotine. In my book, I talk about nicotine itch. So Niche, and the
Yeah,
character of Niche is personified because it's a
yeah,
really, really useful way to get people to understand that you are in a relationship with this creature that does not have your best interests at heart. It's a vampire.
yeah.
It just needs nicotine from you. You have to feed it, and it will do anything it can to make you dependent on it, make you believe that you need it. Um, and so
And,
yeah,
and
Niche it's written humorously, but it's
yeah,
serious.
yeah. Well, and as we said there, the psychological impact in terms of self-esteem, self-efficacy, it's
Yeah.
considerable. It's considerable. Anyway, we have to wrap up there, and I think we need to do a separate one on this at some point. And I want to pull you in to
I
have a
can't
look at the
believe
smoking
it's
cessation.
that's the time. It's
I
gone quite
know, just
quickly.
flown by. Well, it's been so interesting. So, the quick questions here. Somebody said, just a question: is EQ, emotional quotient, correlated to the hypnotic state? Someone, I don't think so, Oliver. I've not seen that. Virtually nothing seems to be that correlated with people's suggestibility, which is a very odd thing for psychologists. And then Katerina says here, a commenter, I agree vapes are very attractive for children because the parents do not feel the cigarette smoke and it looks cool. It's terrible. Yeah, well, to be continued, I think that one. I just want to thank you. That was fascinating. We could have gone on a lot longer on each of these things. That was a great session, and I do want to come back and talk with you more about smoking and particularly the vaping and
Mm.
yeah, get
Well,
this
like I
issue
say, I'm
really
17
turned.
years on from my last smoking client. I mean, it's not an area I was thinking I was going to go back into, but I'm more than happy to go back into it.
I can hear
um,
it's right there. It's right there. You know, all your knowledge.
yeah, I don't know how I was slightly nervous sending a copy of my book because I thought I must be so out of date, but it
No,
sounds
no,
like it's
no.
still
It's very.
relevant.
It was. You know, I was just like, oh my gosh, there's so much in that book. You know, and my whole point is to try and boil things down to simple
Yeah.
because you know it's try and get what's the you know it's about motivation and coping. That's it. You know,
Well,
so
perhaps I'll rewrite it and republish.
well, I might have you have a look at our workshop and our masterclass and see what
Yeah.
see what you think of that too.
Yeah.
Fantastic to have you here. I would love to meet in person at some point, but just so
Yeah.
great talking with you. Oh, and I
Thank
want
you
to
very
let
much. It's been
everybody
a
know
pleasure.
Dr. Chris is working with us on, let's just take 2 minutes on that. Somebody had posted in our forum membership about a client with suicidal ideation and how to refer on. And Krissie, you posted with such great understanding and wisdom, support, but also advice there into that. In terms of yes, but it's also again this opportunity, the person's
Yeah. Every
revealed it to
opportunity you
you,
get,
every opportunity you get,
plant seeds.
even though it's outside your sphere of competence, how do you actually not let that opportunity pass by in terms of a chance now as this person's opened up to you? So based off of that, some incredible sharing there. We were asked Dr. Krissie to do a create a module for us on risk assessment and management.
Yeah, risk assessments and opportunistic risk reduction, I think.
Oh,
So
nice.
you're
Yeah,
not going to keep clients long term because it is outside sphere of competence to work with suicidal patients. But on the other
yeah.
hand, when they're in the room with you, do something useful with them
Do something useful
and
with.
for them.
So that's so that I know we're going to do, but maybe we can do a brief webinar on something around that. I think would be
Yeah.
so interesting. Somebody's mentioning Adrian Wells there, Elizabeth Cudd.
I'm
Yes,
feeling nervous. He's going to fight. Yeah.
he's a little. If you mention his name, you get people get letters. I think
Well, I mean, all I've
his
said is
his
he was the tutor on
his
the course
meta.
and he
You
wants
try
it
and
and he keeps
find the
questioning my
recording
work.
of his metacognitive, the sounds thing that used to be out there, and now
Okay.
he's had everyone take it down.
Okay. I mean, I think he was a fantastic supervisor and he was a very good lecturer. I learned absolutely loads from him.
Very
Um,
enthusiastic. My daughter was at
Very
Manchester,
enthusiastic,
so she
really
met
nice
him too.
person.
Yeah.
I really benefited a lot from his insight and input and teaching on the course. But I don't think that metacognitive therapy is the be all and end all in the world of CBT. And that you should ditch everything else and just do that. It's like I'm not suggesting that he said that actually quite as boldly as that either, but the course was very heavily focused on cognitive therapy and not behavioral therapy. And
Yeah.
actually, I think that if anything, you should redress the balance and be much more behavioral because a lot of babies were chucked out with the bathwater, in my opinion.
Exactly. I agree too on that. There's something to take from everybody, but don't throw stuff away here with this new thing that comes in.
Yeah.
Fantastic. That was just delightful. I would have, yeah, we could continue, but we'll have to go on. Thank you so much. To be
Thank you very
repeated.
much.
Thank you everybody for your kind attention and
I
questions.
only I only saw a couple of questions pop up and I answered them as I saw them. But is there a way of going back to them? Because I'm happy to kind of, provide a written response to a few questions if people want me to.
I don't know, some thanks here from people really enjoyed it. That one about emotional quotient and hypnotic state.
I have to say I have no idea. So
So, and
good
I don't,
answer.
and we wouldn't think of hypnosis as a state either. Paul wants to know the reference for polyvagal theory. That's Dr. Paul Grossman. That's easy. But I can, if you write into me, Paul, you've got my email address. Yeah, you should all be aware that that's quite unsupported stuff out there. Very good. And I'll just mention the other book that I would recommend everyone take a look at, which I haven't got quite to hand here, but it's hard to get, but it's going to come back into print. It's by Dr. Michael Shearinger, psychiatrist in America, on the analysis of 42 scientific claims made in Bessel van der Kolk's book called The Body Keeps the Score. Thank God the man actually did the heavy lifting and looked each one up, and it is quite you. I mean, he starts to get a little bombastic towards the end because he's so infuriated at the fact that a lot of these papers don't even exist, or, or that they were just he's misread them, and it just the whole scientific basis for that book is deeply in question. So unfortunately, the book isn't available in the UK right now because Amazon thinks it's I don't know why he's having to rewrite it and have a different title. But I highly recommend if you're interested in the science, have a look at that book because that's a very experienced psychiatrist who works with trauma, who's actually looked up all references. A notoriously tricky book to navigate, I will have to say, but we can talk about that all later. So thank you, Dr. Krissie. That was fantastic. And yeah, to be continued, I think. To be continued.
Well, thank you very much for inviting me. It's been a pleasure. Really enjoyed it.
You're so welcome. Okay.
Perfect.
I'll send you Siobhan. Don't worry. I'll mention that out for everybody afterwards.
Great.
Take care. Have a great afternoon. Lovely to see you.
Bye-bye.